Welcome. Today we're diving deep into the pharmacist's role in managing post-traumatic stress disorder. We're going to go from the key symptoms to the first-line drugs, and most importantly, the exact counseling points that are going to help your patients stick with their treatment. So let's get right into it.
So here's our roadmap. We'll start with a quick refresher on what PTSD symptoms actually look like before we tackle the modern treatment approach. Then we'll get into the pharmacist's core toolkit, the first-line meds, how to actually talk to patients about them, and finally, how to navigate those common challenges you're definitely going to see in practice.
All right, first things first. Let's get on the same page about the clinical picture of PTSD. Understanding these core symptoms is absolutely key because it explains exactly what our medications are targeting and why some side effects can be especially tough for these patients.
Okay, so the formal definition really boils down to two things: a traumatic trigger and duration. For a PTSD diagnosis to be made, the symptoms have to be causing some major impairment in someone's life, and they have to stick around for more than a month after the event happened.
Now, these four symptom clusters, they're the foundation of a PTSD diagnosis, and a patient has to be experiencing issues in every single category. Just think about what that means in your pharmacy. A single patient could be dealing with flashbacks, actively avoiding places that trigger them, feeling totally numb, and being unable to sleep because they're always on edge. Our medications? They have the tough job of trying to address all of this at once.
So the big question is, how do we treat a condition this complex? Well, it's not just about prescribing a medication. The best approach really involves both psychotherapy and pharmacotherapy, and it's so important to know where each one fits into the puzzle.
This brings us to the two pillars of first-line treatment. And while trauma-focused psychotherapy, has the strongest evidence, medication is considered an equally valid first-line choice. The key takeaway here, the thing I really want you to remember, is that patient preference matters a lot. When a patient actually has a say in their treatment, their outcomes are just plain better.
Okay, now let's zoom in on our domain, our wheelhouse as pharmacists. The medications that are recommended as the initial standard of care when pharmacotherapy is the chosen route. This is our core toolkit.
When you look at all the evidence, it points very clearly to two drug classes as the go-to options: the SSRIs and the SNRIs. Their strength is really in their ability to dial down the symptom severity across all four of those clusters we just talked about. So the guidelines have really zeroed in on four specific agents that are the workhorses for PTSD. You're going to see three SSRIs: fluoxetine, paroxetine, and sertraline, and then one SNRI, venlafaxine. Let's dig into the clinical pearls for each one.
This table has all the nitty-gritty, but let's talk about what this means for you, right at the counter. For paracetin, please remember it's a potent CYPD2D6 inhibitor, so you've got to check for those drug interactions. With venlafaxine, the big counseling point is to monitor blood pressure, especially as the dose goes up. And for sertraline, its pretty weak enzyme inhibition makes it a really versatile and super common starting point.
Okay, so we know the drugs, but how do we talk about them? This next part is all about translating that clinical knowledge into effective communication, the kind that actually helps with adherence and manages patient expectations.
So let me ask you this. What is the single most important thing you can tell a patient who's starting one of these meds? What is that one piece of information that's going to keep them from giving up way too soon?
2 to 3 months. Yep, that's how long it can take to feel the full benefit. This is, without a doubt, the #1 reason patients stop their treatment early. They think they're going to feel better in a week or two. Managing this expectation from that very first fill is probably the most powerful thing we can do to help them stick with it.
So here it is, your 4-point checklist for any new PTSD script. 1. Set that 2-3 month timeline for the full effect. 2. Warn them about those initial side effects, like nausea, but reassure them that they often fade in a couple of weeks. 3. Stress that staying on the medication for up to a year is so important for preventing a relapse. And 4. Always, always, always warn them not to just stop taking it abruptly.
All right, let's talk about the common curveballs because you know they're coming. Patients with PTSD often really struggle with sleep, and questions about other medications are going to pop up. Let's look at how to handle these common challenges.
Okay, this is a huge one. The guidelines strongly recommend against using benzodiazepines for PTSD, and while patients might ask for them, they don't treat the core symptoms. In fact, they can even get in the way of trauma processing during therapy, and they carry a massive risk of dependence, which is a major concern in this population.
So what can we use for sleep? Well, for just general insomnia, low-dose trazodone is a pretty common option. But for those awful hallmark PTSD-related nightmares, prazosin is often the go-to. The absolutely crucial counseling point for prazosin is that first dose orthostatic hypotension. You have to tell the patient to take that very first dose right at bedtime to minimize the risk of getting dizzy and falling.
And what if that first-line agent just isn't cutting it? For patients who don't respond fully, the next step in the algorithm can be to augment with a second-generation antipsychotic like quetiapine or aripiprazole. This is usually reserved for more treatment-resistant cases, and it can often help with those hyperarousal symptoms.
Let's end on this note. The evidence is crystal clear. When patients have a say in their treatment, they just do better. And as the most accessible healthcare professionals out there, we are in a perfect position to support that shared decision-making. By reinforcing what their doctor said and by validating a patient's concerns, we do so much more than just dispense a pill. We become a really crucial part of their recovery. And that's the kind of impact we can have right there at the counter.